Good evening to everyone who's logged in on this third episode of our WIGIL Journal Clubs series. Today, Dr. Arpitha, second year surgical gastro resident from Sakra World Hospital, will be presenting an interesting journal from JAMA Surgery, journal article from JAMA Surgery. Moderating the sessions will be a senior consultant in HPB surgery and liver transplant from AIG Hospitals, Dr. Sumana R, and joining her will be Dr. Jaini, Associate Consultant from Sakra World Hospital. We all know, we've all heard the term prehabilitation, and instinctively it makes sense. Obviously, optimizing a patient before a major surgery should improve outcomes. But however, there's not been a lot of conclusive evidence that it helps, especially in GI surgery and other major operations. So this should be an interesting session as Dr. Arpita will take us through this article which discusses the role of prehabilitation and its role in major hepatectomy.
Good evening, everyone. Today I'll be presenting the journal club on the topic prehabilitation with exercise and nutrition to reduce morbidity of major hepatectomies in patients with sarcopenia. It is a randomized control trial which was published in JAMA Surgery 2025. So the hepatectomy along with the chemotherapy for selected patients with a primary and secondary malignancy is considered as a standard treatment. Although this morbidity ranges from 20 to 60%. Suppose if the patient has to undergo a major the hepatectomy, the mortality raises up to 5% and the morbidity up to 70%. These patients with a liver malignancy, they usually have a impaired liver function test, either due to cirrhosis, neoadjuvant chemotherapy, or cholestasis, which increases the unexpected post-operative events. So it is important to optimize the patients to minimize the unexpected post-operative events. There are several traditional the factors which are available which significantly affect the complication rates after surgery, namely age, comorbidities, the BMI, performance status, ASA grading. But this sarcopenia, it is a superior predictor. So what is the sarcopenia? It is defined as a degenerative loss of muscle mass, strength, and function. Its prevalence among the cancer patients ranges from 30 to 74%. So it predicts the worst short and it predicts the worst short and long-term outcomes. So a recent data has suggested the exercise and nutritional supplementation. It reduces the post-operative complication and enhances the recovery. So there are several studies which were available for other surgeries, especially in the colorectal surgery, which showed a reduced complication with the pre-rehabilitation. But there are no data for sarcopenic patients in major hepatectomy. So the hypothesis of the study is this intervention, it could reduce the post-operative morbidity and improve functional recovery compared with the standard surgical care alone. So the objective of this the study is to determine whether a 6-week multimodal prehabilitation program combining the physical exercise and nutritional support reduces post-operative morbidity in patients with sarcopenia who are undergoing major hepatectomy. So it is a single-centered randomized control trial which was conducted between the period of April 2022 to January 2025 at Tertiary Hepatobiliary Referral Center in Italy with a study population of 60. So sample size calculation was based on the expected reduction in the postoperative morbidity from 60 to 30% with the alpha value of 0.05 and power of 80%. The required sample size was calculated as 60 patients. A 15% dropout rate was accounted for in sample size calculations. So these are the inclusion criteria and exclusion criteria. All adults greater than 18 years with a radiologically and functionally confirmed sarcopenia were included. Diagnosis of primary and secondary liver malignancies requiring major hepatectomy, and patients requiring strategies to induce the hypertrophy of the future liver remnant, including portal vein embolization or portal vein ligation during a 2-stage hepatectomy. Exclusion criteria were minor resections, patients who qualified for major hepatectomy without the need for FLR hypertrophy, patients who had a benign liver diseases or the extrahepatic cholangiocarcinoma, inability to delay surgery by at least 6 weeks, and ALPS procedure, severe kidney dysfunction, physical disabilities, precluding exercises. So methodology. The sarcopenia was assessed both qualitatively and quantitatively. Qualitatively, sarcopenia was defined using the skeletal muscle index. The skeletal muscle index is a skeletal muscle area to the height of the patient. It was based on the baseline CT scan at the lumbar L3 level, psoas muscle. So the cutoff value for in males is less than or equal to 53.5 centimeters square per meter square. And for females, it is less than 40.8 centimeters square per meter square. So these calculations were performed again after the 6 weeks after the pre-rehabilitation program. So qualitatively, the sarcopenia was assessed based on the hand grip strength test, gait speed test, tricipital and subscapular skin fold caliper. So in the pre-rehabilitation group in the methodology, the 6-week program was offered before surgery with a daily 30 minutes brisk walking or greater than 2000 additional the steps, which was tracked via digital pedometer. In hospital, twice weekly, 60-minute supervised sessions, strength plus aerobic training with the physiotherapist. And nutrition-wise, it was concentrated. It was targeted both protein and calorie intake, with a protein intake of target of 1.2 to 1.5 gram per kg per day, and calorie intake of 25 to 30 kilocalories per day. It was supplemented twice daily for first 4 weeks, and the last 2 weeks was daily. In the control arm, the standard was offered only standard perioperative care with no structured prehabilitation. Both arms followed the institutional ERAS protocol. So the outcomes of the study, the primary outcome was the incidence of postoperative complication within 90 days, which was assessed by Clavin-Dindo classification and the comprehensive complication index. The secondary outcome was major complications, 90-day postoperative mortality, readmission rate, and post-intervention changes in the sarcopenic status. Coming to the results. So total of 136 patients was assessed for eligibility, among which 66 were excluded. 70 patients were randomized. In that, 10 patients were excluded, one because of the tumor progression during the interstage and insufficient liver hypertrophy. So the final sample size was 60. 30 patients were randomized in each group. So the characteristics of these two groups were well balanced. The median age was around 69 years, with 28 female patients and 32 male patients. Most of the patients belong to the ASA grade 2. And most common indication for liver resection was colorectal metastasis, constituting around 40 patients, that is 66.7%. In the technical aspects, the 52 patients underwent portal vein embolization and 8 patients underwent portal vein ligation. These are the intraoperative and postoperative course of the 60 resected patients grouped by the intervention. Here, one patient died within the 90 days from the surgery because of a post-hepatectomy liver failure. That was he was in the standard care group. Overall morbidity was found in around 19 patients, among which 15 were in the standard care group and pre-rehabilitation in the 4 were in the pre-rehabilitation group. It was clinically significant with a p-value of 0.05. Among this morbidity, there were 6 major morbidity, all in the standard care group. And all other morbidity, majority of the morbidity were belong to grade 2. There are also increased hospital stay and readmission rate in the standard care group, although it was not statistically significant. 90-day mortality was seen in one patient, which constituted around 1.7%, and morbidity 31.7% overall, with an absolute risk reduction of 36.7%. So all major complications constituting around 10% were in the standard care group, with a number needed to treat were 5. The anthropometric characteristics were compared between the baseline and after the 6 weeks right before major hepatectomy. So in the pre-rehabilitation group, the skeletal muscle index and the hand grip strength were significantly improved. So this PreHep trial is the first randomized controlled trial to evaluate the impact of a structured multimodal prehabilitation program in patients with the sarcopenia undergoing the major hepatectomy. 37% risk reduction was seen in postoperative morbidity in the compared to standard care group. Sarcopenia has been recognized as a clinically relevant predictor of adverse surgical outcomes in patients with a malignancy. In a previous prospective study conducted by the same center, the reduction of muscle quantity and quality was independently associated with a higher rate of 90-day complications after the liver resection for malignancy, which led to prolonged hospitalization and increased admission rate. So this current trial confirms these association. The sarcopenia is not exclusively a marker of frailty, but a modifiable risk factor through preoperative intervention. There was one study which was conducted by Fatima et al., which showed a preoperative combination of exercise and nutrition improved the physical fitness and shortened hospital stay in patients undergoing liver and pancreatic resection. This study was not restricted to sarcopenic patients, and it was a non-randomized design. So this exercise and nutritional supplementation helps in the reducing the postoperative morbidity by a multifactorial. It stimulates muscle protein synthesis, modulate the immune function, and increases the insulin sensitivity. So patients with sarcopenia often present with a subclinical inflammation, impaired functional reserve, and altered drug metabolism, factors that may exacerbate the surgical risk. Therefore, for individuals scheduled for major hepatectomies and requiring strategies to induce the hypertrophy of the FLR, intervening during the interval between portal vein occlusion and the definitive surgery, it provides us a unique opportunity and time for us to modulate these factors. So coming to the limitations of the study, this is a small sample size containing only 60 patients, and it is a single center design. And so it limits the reproducibility and rigorous sarcopenia definition. But it was assessed both qualitatively and quantitatively. So results apply for only those sarcopenic patients. This was a 6-week program, it was a 6-week program. It was limited to patients delaying the surgery. So only for those patients who required FLR hypertrophy or neoadjuvant suspension, this 6-week program can be utilized. It is powered for only the morbidity. Secondary outcomes like mortality and the major complications should be practiced with cautious. And also both we can't isolate whether the nutrition or exercise the effects, or both are needed to reduce the postoperative outcomes. A small sample precludes the subgroup analysis like long-term outcomes, the recurrence-free survival, and the quality of life. It needs the future studies. And in this study, it was not clear whether the patients who underwent neoadjuvant chemotherapy was included in the study sample. And since the most common indication was colorectal metastasis, it is not clearly defined about the treatment of the primary malignancy. So, conclusion. Findings of this randomized clinical trial provide evidence that prehabilitation improve postoperative outcomes in patients with a sarcopenia undergoing a major liver resection. Integration of structured exercise and nutritional support into the preoperative management of high-risk patient represents a novel and promising strategy to reduce the surgical morbidity. There are the similar studies. One such study is the influence of prehabilitation in patients with a liver cirrhosis before liver transplantation. It was a randomized clinical trial which was published in European Journal. It showed improved liver frailty index and functional status after 1 month, suggesting prehab can be safely used in this high-risk group. And also, apart from the liver surgeries, there are other surgeries in which prehabilitation program was conducted. One such is the effects of multimodal prehabilitation on postoperative outcomes in colorectal surgery. It is a systematic review and meta-analysis which showed fewer severe and medical complications when compared to standard ERAS protocol, with improvement in the functional capacity.
Are you done?
Yes, ma'am.
Okay. Okay. Actually, you said it's a novel thing. What is the novelty in this?
The previous studies was not included this only particular to sarcopenic patients and in the major hepatectomies.
No, don't go by the study. Now you're in second year, right? Are you in second year or first year?
First year ending, ma'am.
Your first year ending. Okay. So now you have studied this paper and you have understood what they've tried to do. We all know that it is very, very clear and you put it across, right?
Yes, ma'am.
The prehabilitation is not something new. Do you agree?
Yes, ma'am.
So what is the new thing that you've found here? I mean, I agree that this is a good study. There are limitations, there are some flaws, there are some good things, everything. But forget about the study and you tell me your viewpoint where you can use this in your regular practice. Forget that it is a liver surgery. You're a GI surgeon. So prehabilitation, talk about prehabilitation.
Prehabilitation, it can be utilized for any major surgeries, in particularly in the geriatric patients, to improve the postoperative outcomes, to reduces the postoperative morbidity, to decrease the frailty in these patients.
You don't decrease the frailty. What do you do?
Improve both the nutrition as well as the physical activity.
Okay, that is one part to it. Okay, so this can this be used to even general surgery?
It can be used.
Yeah. So where have you used a bit of prehabilitation in your general surgical practice? Simple. Take up something simple, a hernia surgery.
Yes, ma'am. Hernia surgeries.
What do you advise?
Preoperatively, will ask them to be active, do some physical exercises, then improve the nutrition, and also to give them to increase the lung capacity with the incentive spirometer.
Weight loss. I remember saying always weight loss before we go
Weight
for hernia
loss.
surgery. So now
Yes, ma'am.
don't get. I think what I'm trying to say is that use these things in your clinical practice, right? So
Yes, ma'am.
any person, okay, now you said it is a novel thing. Okay, it's a randomized study. You said, okay, not many studies have been done. Everything is fine. So what I want you to understand is that what is your take-home message from a study like this? And you can extrapolate it to every GI surgery, even simple cases, Whipples, whatever you're doing. It's not an exam, Arpita. You can open up. We are not going to give you marks here.
Yes, ma'am. So the patient awaiting surgery, to increase their post-operative the functional capacity, their nutrition, we can during those elective period we can allow them to we can ask them to take a good nutrition with both calorie and protein. We can ask them to be active with exercises, and to increase the lung functions. So all the major surgeries with electively awaiting for the surgeries, we can
Basically,
ask
talking
them
about
to.
nutrition and strengthening exercises. That should be very specific. Okay, I'll allow everybody else to ask some questions and continue the discussion. I think I'm Jaini. Hi, you can take it forward.
Ma'am, I think the reason we chose this and what we can take away is that maybe for major surgeries, we can have an institutional protocol for a more structured rehabilitation program. I know most of us do advise for spirometry and increasing number of steps, other measures in patients awaiting surgery. But I think maybe coming up with a structured institutional plan and maybe pamphlets with the exercises recommended and other things would be helpful for patients.
Exactly. That's what I think Arpita should have put across. It's not just incentive spirometer. There is no use of giving nutrition or giving 1.5 grams per kg of protein if you're not doing strengthening exercises. That should be there in your mind. So sarcopenia can be improved with not just nutrition but strengthening exercises, and then taking care. And actually you cannot just tell them, and you have to reassess. Like, say, if you're going to make pamphlets and make a protocol for your institution, this has to be reassessed objectively and to see if you can, like, say, obviously we can't do for everybody, so if you can, you should do this and then maybe take it forward. If anybody has any questions regarding the study, please. Do you have any question, Arpita?
I think one of the problems with the rehabilitation studies is it's like I said, it's intuitive. We feel the benefit will be there, but the problem is quantifying it. How much duration and what is the end point? I mean, we know our population is significantly. I know they've chosen sarcopenic patients, but even among sarcopenic patients, our population tends to be much more sicker, much more malnourished. So, how much prehabilitation is enough? Like, is it 5 kg weight gain or albumin increase, or is it minimum 2 weeks? I think the problem is always in finding a target, saying adequate prehabilitation. I think that's a problem when we come to quantifying it. Here again, I think it's been a blanket 6-week regimen, and there's no endpoint to see.
No, I
Okay, this
think
has improved.
they said that they have reassessed the sarcopenia index, isn't it?
Yes, ma'am.
It's a
It was reassessed.
significantly different. Was it
Yes,
statistically significant?
Statistically significant.
Yeah. So objectively, if you can do it, actually, like Gayatri is telling, if you take our population, I think there are a lot of things, not just our population. If you look at, just remind me, when was this study done?
2025, from 2022 to 2025, mid
2025. So what like doing so many liver surgeries, what I've noticed is that, at least in our population, is that, see, we have a lot of NASH. Like, say, every other person who comes has NASH, and obviously when there is a disease process that is happening in the liver, if it is a primary liver cancer, we see that the quality of the liver is not good at all. So these patients, like Gayatri said, our population, especially women, the albumin is like really, the nutrition is actually really bad. So to actually go and say that, okay, we'll get the sarcopenic index to a significant level, I'm not sure how we can actually do this. Or if you look at the clinical practice, the problem is that these patients cannot wait that long. But still, if you insist, and at least even if you don't have an objective, you may not be able to do only for study sake you can do it, but you can't expect the patient to go through another CT to see if the sarcopenia index has improved. Those things, but at least the nutrition part and some kind of physical exercise does help, and I've seen that the morbidity drastically reduces, and we don't see them coming back with any kind of infections, or liver failure is not that much, because you tend to sort of prepare them nutritional. Basically, nutrition itself, I think, will help the these NASH livers to improve within a matter of 2 weeks. That is, though I don't have a study to quote, but this is my clinical experience, and I've seen that you give them a clear nutritional plan, and just ask them to do some kind of exercise, half an hour or 1 hour a day. That itself improves the liver. I can take an example of recently one patient that we did. Um, Hylarcolangio. So this patient, we tend to do a elastography or HVPG before we go for a right hepatectomy in these patients. The HVPG was on the higher side. So the prehabilitation, though the some people don't agree that we should bring down the bilirubin to a significant level. People say you can go ahead with around up to 10 and things like that. But once you bring down the bilirubin and give them a plan for about 2 weeks, actually this patient, which we initially said that we cannot operate and said inoperable, we finally went ahead, and after he lost about 5-6, this was purely NASH. He lost about 5-6 kgs, and then we reassessed with the elastography and saw that there is a significant difference. So, and this patient initially was called for that inoperable because of the liver itself. Now has gone back home without any morbidity. So this then I would suggest that all the juniors, especially Arpitha, when you read a paper like this, immediately your thought process should go to how can I do even in a simplest surgery that I'm doing. I know in the corporate system we don't get that kind of time, and also because our patients are paying, they themselves may not be ready, but there is a way that you can actually do it even if you're not quantifying it after 2 weeks.
I think the other thing is things like hand grip strength are a very good
Yeah.
correlative for skeletal muscle index and much more easily reproducible.
Yeah, these studies
Doesn't
have been
require
done
a
in
lot of.
transplant. Like say, transplant is a known thing for many years now. Frailty index, and we used to do hand grip strength and that subcutaneous fat, everything, the measurements. So I think that is being extended to hepatectomies. I agree with you. Anybody else who wants to ask any questions?
And also, I would like to say, like this in this study, they have quoted to be a 6-week period. For majority of the patients, we can't wait 6 weeks or something. So the further studies should be done to see what could be the minimum period for which prehabilitation might be administered for the the patients with this, particularly the cancer patients, because we can't wait just for prehabilitation for 6 weeks or something.
No, I think
So
if I'm right, they said that people who had FLR enhancement procedures most of them were
yes, ma'am.
done.
In this
So they have
study,
to
they are
anyway wait
waited.
for 6 weeks, 4 to 6 weeks.
Yes, ma'am. I'm generally saying, like, apart from these, the patients who doesn't require FLR, or the other patients who has this colorectal cancer or something. So I think further studies are required to see the minimum period through which we can improve the the nutrition status and strengthening exercise.
Don't you think in colorectal cancer you will say that, okay, if you have used bevacizumab, then you'll say you have to wait for 4 to 6 weeks, and even if not the second regimen, but if you are saying that, okay, we still have to wait 3 weeks, even if you have given capecitabine also, you are saying that you have to wait for 3 weeks, right? So extending another 2 to 3 weeks in these patients, I don't think will harm them. But like I said, objectivity is
Well,
very important.
extrapolate.
You have to objectivize these things and say at what point you should look at it. Is 6 weeks actually ideal? Why did they take up that 6 weeks? Mostly because I thought that they have done FLR enhancement and they were waiting for 4 to 6 weeks anyways. Any more questions? Gayatri? Jaini, what is your thought on rehabilitation in ripples?
So, ma'am, that was Shrujana's thesis topic because I had done my thesis on the impact of frailty on post-operative outcomes. And what we had found was that although POPF depends on pancreatic texture and a lot of other technical factors. Among the patients who were having POPF and PPH, the failure to rescue was much higher in patients who were frail. So that Srijana had done her thesis on prehabilitation in patients who are on neoadjuvant or high bilirubin being stented for whatever reason, waiting for 4 to 6 weeks. We saw a significant decrease in morbidity and mortality, especially pulmonary complications, severe grade C POPF, and mortality following onset of severe POPF.
Yeah, I think she presented somewhere and got an award, I guess, right? So anybody else, any questions, or should we close it? Do you have any questions for us, Arpitha? Alrighty. Gayatri, are we closing? Sorry.
Are there any questions from the audience? Any suggestions, comments, anything?
Okay.
Dr. Vibha, Dr. Yamini, would you like to weigh in on the discussion? I think you can all unmute.
So I just wanted to say that whether you term it as prehabilitation or the wait period of 6 weeks, we all in general, for all our patients, we start them on some exercise, whether it's weight training or respiratory exercise and nutritional supplement when we plan a major operation. So I think this paper just reiterates the fact that every individual who goes in for a major surgery, and if you feel that they are frail or sarcopenic, there is a role of rehabilitation. And that definition of rehabilitation can be modified according to the setup where you're working, according to the type of patient and the type of surgery. But I think our take-home message from this paper and many other papers, in fact, is that if you have prehabilitation in some form, it improves the post-operative outcome.
Yeah. See, I feel in this.
But in terms of decision making, let me just bell the cat. If you have a severely, like a frail patient who needs a surgery, but you've given a period of rehab, they don't improve, you're not going to not intervene. It will be more like a prognostic tool at that point, right? I mean, the outcomes are likely, I mean, not likely, but it could be poor if there is any morbidity or any issue. The patient's reserve is less. But regardless, you will go ahead if the biology per se is okay, right?
No, that is true, because like you can't keep on waiting forever. So this idea of 4 to 6 weeks has come purely because these people have looked at the people who have had FLR enhancement. Otherwise, also if you're asking me clinically, like say in our clinical practice, you tend to weigh a lot of things. You are not going to just go by, oh, how frail is he? Should I go? There are pre-operative things that you're going to do, intraoperative things that you're going to do, and post-operative things to do. Lot of patients who come to you have NASH. They have either fibrosis or fatty liver. So intraoperatively, also you tend to modify your procedure in such a way that there lot of parenchyma preserving surgery is the one that I would suggest. Like say, this is what I always look at. You give them a good clearance, good. If you're doing a say hilar cholangio, there are multiple ways you can actually reduce or increase the FLR by just doing some kind of inflow and outflow adjustments and parenchyma preserving and things like that. So that is a different subject altogether. Like say, that's a total discussion away from what we have actually discussed today. So you have to, in your practice, you have to weigh, like say, look at multiple factors, the cost benefit also, whether if you're going to go on for too long, is it affecting the patient? finances, like say so many things. So so I would say at least 2 weeks, if these people are frail and you can still, even if you have not gone for a FLR enhancement, two weeks will change the quality of that liver. And then the liver quality is what defines the morbidity in these patients. So there is no exact time, exact amount. Nobody can, I think, give you. Even in transplant, we don't have an exact, 1 month, 2 months. It is just what was pre and what you after rehabilitation, what have you come to? That's what is a clinical decision. Objectively, if you want to do, there are multiple things like, so albumin, but they all take a lot of time. Your daughter is also listening to
Are there any more? Yes, she wouldn't stay out of the room. Sorry.
No, it's okay.
If there are any more points that anyone would like to raise, any experiences or anything to share, otherwise, it's been a short but sweet discussion. I think the take-home message is clear. I think we've all been doing it in some form throughout our years of practice, but objectively to say that it actually reduces, we can put a figure to it, that there is actually improvement.
Like Jaini said, I think
And
every institution should have its own protocol.
that there is benefit, even if it's in 1 week while they wait for financial whatever arrangements or whatever. If we can put in some effort, there is bound to be results rather than nothing at all. So I think that's a important message. Dr. Yamini, you want to share something?
Everybody should make their own institutional protocol and follow it, I guess, or keep reinventing every few months or few years what is the best that you could do for the kind of patients that you're getting in your practice. Like Jaini said, I think that's a great idea. All of us should try to make one for ourselves. Thank you.
Okay. Thank you, everyone. And
Thank you.
thank you.
Have a good night.